I'm Antoni Chan. I'm consultant rheumatologist from Reading, United Kingdom, and I'm here in Eular 2024 in Vienna. And here at the conference, there's been a lot of new developments in the field of digital rheumatology, particularly looking at areas such as machine learning and artificial intelligence, and how we can leverage that into the whole field of rheumatology, from the diagnosis to the management and to the prognostication for to help with our patient care. And there was a session that ran here at EULA 2024, looking particular in this topic. And I'm very happy that I'm joined today by Professor Thomas Hugle from the University Hospital Lausanne in Switzerland. And he did a very nice oral presentation. The number is OP0112, where he used a model of calcium pyrophosphate deposition on hand radiographs and how deep learning model could be used for an automated detection of patients with CPPD. So, Thomas, thank you for coming to join us here on Room Now today. I wonder whether you could tell us, introduce us to the area of your presentation, and then maybe in the second half we can kind of look into the future as well as to how this whole field would go forward.
Thank you, Anthony. It's a pleasure. So, the idea of this study was based on the new classification criteria for CPPD from last year, 2023, the Euler ACR criteria for the classification of chondrocalcinosis or calcium pyrophosphate deposition disease. And so you can, diagnose CPPD also without proof of crystals in the joint fluid. So by, well, clinical parameters and radiological findings, for example, or ultrasound findings. So, and on hand radiographs, you can find quite a lot of signs. Obviously, we know this from the clinic for CPPD, like TFCC calcification, but also MCP2 or 3 calcification, or osteoarthritis as specific sites. So we trained a model to recognize calcification on TFCC or MCP3 or 2 on hand radiographs. And this was that's labeled by 2 independent radiologists, by my colleague Fabio Becce from Lausanne. Mm-hmm. And then we trained the model in almost 1,000 radiographs. Of those, around 300 positive for TFCC. We trained a classical convolutional neural network to recognize either TFCC calcification, MCP2, 3 calcification, or combined model with all 3 of them. And the findings were clearly that the combined model detecting TFCC, but also MCP2 or 3 calcification is the best. Mm-hmm. We got an accuracy of 0.85, which corresponds to, let's say, a sensitivity of 77%, a specificity of 80% in a relatively small data set. We also then looked at it as specific sites of the lesions and, did the 5-fold cross-validation to see how it is. But the best is actually a combined model followed by a TFCC model for the detection of CPPD. We also showed some heat maps. Heat maps are very interesting, I think, also for clinical implementation because they show you where, let's say, the region of interest for the algorithm. So the area on the radiograph where the algorithm took its decision. Well, I think heat maps will come into clinical practice to help us, to guide us the way to diagnosis, if you wish.
So very promising results. Obviously, as you say, still early days and small number. What was the area under the curve when you did the calculation? Because increasingly, it's one of those areas where we kind of now have to look at sensitivity and specificity, and also the AUC.
Yeah, it was 0.86. And we also calculated the area under the precision recall curve,
right, yes,
to be a bit more precise because it was an imbalance data set, meaning more CPPD negative than positives.
Mm-hmm.
And so we used the AUPR, which was 0.77.
Yes.
And again, best for the combined model, followed by the TFCC side. And then, much weaker was MCP2 and 3. I mean, that's what we also see in the clinic.
Yeah. So, for our listeners, these seem to be the new parameters now, where we are increasingly being exposed to this whole area of evaluating the sensitivity and also the specificity of this particular test, and then looking at the area under the curve. Now, very promising results. Where do you think along the patient pathway will we be using this, in the early stage of diagnosis, or when the diagnosis becomes more challenging? Because can be quite a challenging diagnosis to make. CPPD, sometimes we are confused with maybe, say, a different type of rheumatic condition.
That's a good question. The other rationale to do this study was actually to have a tool to screen other larger databases.
Okay.
So we already did this. It's notably interesting in RA. So we used it to screen our national registry data set with around 12,000 RA patients, but we cannot just score those images for CPPD. So the algorithm is very helpful. And we found that almost 25% of our RA patients were actually CPPD positive, right? So in first line, we want to use it to screen it in other databases or clinical trial, whether CPPD is a confounder, for example, in RA. This is very interesting. And then in clinical practice, I think either way, it's probably more a bit in the elderly patients where, patients over 80, almost 50% has somehow CPPD. I think it will be maybe more on the later stage. I think we will combine CPPD detection also with RA detection and OA detection or PSA detection. And I think notably in combination with other models for RA, PSA, etc., this model will be interesting as a diagnostic tool potentially.
And how do you see this, particularly in that patient group where they're a bit older, maybe more females as well? How did the model will, do you project that the model will be able to differentiate between OA, which is probably very highly prevalent in that population, with the CPPD?
That's a good question. Here, this model I presented was purely on calcification, right? We have published another model to detect DIP osteoarthritis. So that's the next step, actually. We want to combine the calcification model with an OA detection model, so we know exactly what is calcification, what is OA, and then potentially also with clinical data to give predictions.
So you're training a model, but then the eventual application may be beyond CPPD. It's in other areas where it can also be refined and
clinically
sharpened up as well.
Yeah.
So here at the Eular, there were a lot of other interesting presentations, certainly in your session, which we all enjoyed attending. I wonder whether you wanted to share with us some of your highlights from maybe that session that you were presenting at.
Yeah, so a lot was imaging. And I mean, that reflects a bit the over 800 FDA approved AI algorithms. Most of them are in imaging. And that was also the case in this session. So there were different types, for example, predicting progression of knee osteoarthritis by MRI, or actually in arthralgia, the use of MRI findings, to predict the development of arthritis. That was interesting. One highlight was actually a technical issue that one speaker showed first relatively good results, and then he pointed out a technical problem, how to interpret the results of the algorithm, and showed that it was actually not that good. So they had to retrain it, and so that gave me some methodological insight. There was one paper on a large language model for patients receiving joint replacement. Actually, also methodological paper to design questionnaires, then to assess patient satisfaction. I think those were the ones, and another one on bone remodeling markers, and then to predict actually inflammatory arthritis. I find that was also very interesting.
Yeah, it seems to be in quite a lot of areas now where certainly in my sort of own area of interest in the spondyloarthropathies today, there was a lot of good poster presentations, but particularly looking to some of these areas as well. So from early diagnosis to prognostication of patients' response to treatment by using machine learning algorithms to work onto that. So any other things you'd like to kind of share with us from this session in the whole field of AI and machine learning before we sort of close?
Oh, I mean, imaging is number one. I think simple tasks such as detecting calcification will be automated, or you will have a support by AI models. Clinical predictions are more difficult. We have seen this. I think that the AI models could help maybe in the shared decision process. They're too complicated just to rely on, especially when it comes to treatment decision, which type of drug you should take. So I have nothing seen that tells me which type of drug we should use. So we are waiting for this kind of studies, but it's promising.
Yeah.
A lot will be integrated in the electronic medical health record. I think that's important to have, that those algorithms support us and save time, not create more time by opening a browser or something.
Yeah.
They should be accessible, and then I think AI will be very helpful.
Looks like we are on this journey now. Certainly from Eular 2024, it seems like the community is taking this on. We're not there yet, but I certainly can see the direction of travel being there, that will get better in terms of stratifying our patients to hopefully achieve one day, which is our great aim of personalized medicine. So thank you very much, Professor Hugle, for your time today, and hope you enjoy the rest of the Eular.
Thank you very much.
Thank you.